a week or even, I mean, usually it's a few days, but it's the longer it's on there, the more problem you'll have. So if you're having problems like this, most people aren't having problems, you know, make sure that you get rid of that beta quickly. But let me, go ahead. And no problems, right? There you go, see? That's usually my take, is that most people have, it's a gentle touch, it's your doctor, right? Absolutely. And also it's a case-by-case basis. Like I said, you know, you can usually case a patient out just by talking to them and listening to them and seeing how they are. And that's called the art of medicine. Now, I have to continue because I was just given the 10-minute mark here. So I'm going to show you the science of medicine. How's that? Now, the current treatments that we have right now are all injections, at least at this time. And the reason why they're so good is because of this graph. This graph shows a typical treatment regimen for these injections with Lucentis. This is the first time any drug has been able to increase vision rather than just prevent it from getting worse. Okay? Remember, that first laser treatment I was telling you about? I would tell you your vision would go down like boom, like this, and then it would level off. Okay? And that's why we did it. But this is the first time where we've had medicines that have been able to do this opposite. Now let me go over historically. I'm going to go over, there's the three medicines I mentioned that are currently available. Macular, Lucentis, and Avastin. Okay? I helped develop all of them. I worked with Macular for a long time. I worked with Lucentis for a long time back in the 90s when in the basic science lab, and then I followed it through the clinic. So I know these molecules intrinsically, like they are my babies, okay, because I grew up with them. Macular was designed to be the safest drug of its kind, okay? Now, the problem is and I have a picture here of EcoSmart, okay? It's safe because it likely will have the least systemic side effects of this class of medicine. What I didn't tell you was that this VEGF molecule is very important for your heart and also very important for your brain. VEGF, so let's say you're having heart problems and you're not getting enough blood flow, okay, to your heart. Well, what you have to do is the heart calls out this same molecule called VEGF. So it can reperfuse, meaning get more blood vessels to feed the heart so it can get more oxygen, right? So it's pretty important, don't you think? So that let's say you had a heart attack and you need to recover from the heart attack. The only way you can recover is for blood vessels to grow into the heart. Well, that requires VEGF. Now, what happens if you block that? And injecting an anti-VEGF in the eye, and you block that and you're having heart problems. Well, there's a chance that would cause you to have another heart attack. You would stop the reperfusion, okay? And this drug, Macular, is the only one, it's a selective inhibitor. So VEGF is actually a family of proteins. Now, like a family, not all the family is bad. Some are good, some are bad, okay? In the VEGF family, there's one player called VEGF 165, and I'm not going to explain to you what that is. That's the name. And I call him the Gaddafi or the Assad or the bad leader. He's the one that causes all the problems. And this is what this guy selectively inhibits. I call him the sniper. He's special forces. Okay, he's not going to put on an all-out war, but he's going to go in there in Gaddafi's or Osama bin Laden's compound, get rid of him, and then we won, right? That's what Macular does, and he's very good at that. The problem is that sometimes you need to get rid of all the players initially, sort of like a coup, right? And that's why you have to use the other medicines, which are Avastin or Lucentis. Now, I have a problem with Avastin. Avastin is a drug that I worked on back in 1994. It's actually a cancer drug. Now, cancer drugs, the reason why anti-VEGF therapies are useful for cancer is because if you stop blood vessels from growing around cancer, then you can choke the cancer, right? And that's what Avastin does for a particular cancer called colon cancer. Now, At the same time, remember I was working at a cancer lab. I was also working in the same lab with a bunch of ophthalmologists who were students of my dad. And we were going, well, you probably could do this for the eye as well. And so we used this molecule, and it was the first molecule to be tested in an eye model of macular degeneration. And it worked. But the problem was there were a lot of problems. Avastin is a very inflammatory molecule. It's called an antibody, okay? Antibodies are part of your immune system, and it causes things to get inflamed. So we said, well, we probably can't use this in the eye because it will cause the inflammation that we were talking about, the iritis and the uveitis, right? Well, we then developed something called Lucentis to replace it. Lucentis is actually a fragment of the antibody. Just an arm. So an antibody looks like the YMCA, you know, when you do YMCA, the song, it's an arm of the Y. So it's this one, right? It was one arm. It's not as inflammatory, and it was actually designed for the eye. And it was also tested for the eye. Okay? And this is what showed tremendous amounts of improvement in people's vision. Now, Macugen was the first, but it was designed for safety. It worked, but it wasn't as efficacious as Lucentis, right? But Lucentis had some theoretical issues, and I have a cartoon here that says, you know, I have a prescription for arthritis, but it may cause a heart attack. The second prescription is for the heart, but then that's going to cause damage to your liver. Well, that's the problem because VEGF, the whole family of VEGF molecules, are so important throughout your whole body. And we have some information that says that maybe, just maybe, Lucentis, if used in a patient who's had a stroke in the past, may induce another stroke. Okay? Well, but still, you know, but we found this data to only be important in patients who've had strokes before. So if you've had a stroke before, I'd be very wary about giving you an injection of this because it might cause another stroke. Okay? And that's when I would use the drug called Macugen. Or same thing with heart, a heart attack. Remember, I was studying the molecule VEGF, and I was working with cardiologists, neurosurgeons, neurologists, on trying to use VEGF, not an inhibitor of VEGF, but VEGF to be upregulated in the heart to help with heart attacks, upregulated in the brain to help with strokes. And you know, some people have this blockage of a leg artery. Well, Dr. Isner, who's passed away now, he developed a treatment that he would infuse this VEGF into that limb so it would reperfuse and then you could walk again. Okay? So this is my background, and that's why I'm very wary about the drugs that we're using. Now, I'm not telling you that you shouldn't use these drugs, okay? Because they're very, very effective. But you have to be familiar with them, and that's why I have this cartoon that says, you know, everything, good or bad, has a side effect. And you've got to make sure you're aware of what those side effects are, so that you don't, you know, if you've had a stroke before, well, be wary that you shouldn't be, you know, you should be aware that it's possible that it could increase your risk. Now, we're involved now in testing the new generation of drugs, and I'm going to just go over them quickly. I only have 5 minutes, but what I'm going to start out with is the newest drug on the block, a drug called VEGF trap. It's actually been renamed Eylea. Now, the benefit of VEGF trap is it is like Lucentis, and it's as strong as Lucentis, but you don't have to inject it as often. Remember, these are like weed killers, and if you live in Florida, you understand that, you know, you might squirt weed killer one month, but then you got to reapply it the next month because the weeds are still growing. That's the same way with the weeds inside your eye. So we've developed new drugs, and this one is the one that's coming out right now. It actually was just approved yesterday. And it actually, instead of having to inject it every 4 weeks, we inject it every 8 weeks. Yeah, all right. And it's been shown to be equivalent in strength and efficacy as the every 4 weeks of the other drugs. Okay? So that's a big breakthrough. But still, it's every 8 weeks. It's also, it's a lot safer. It has what we call remember I told you the Avastin that was used this is as strong as an antibody, but it's not as inflammatory. It's actually not as inflammatory. And you know, the safety issues seem to be as prominent with this molecule as the other molecules. But still, I mean, you know, it is an advancement. Our site was the lead site to testing this drug in the last 5 years. So we know a hell of a lot about this drug. Another drug that we're working on is something called anti-PDGF. Now this is very early stage. The thing is that what we found is that with these medicines, these anti-VEGF medicines, they're very good if we catch the lesion early. What does that mean early? Well, before it's matured and become sort of scarred a little bit. So most of our patients that come in, at least if it's their first eye, we catch them very late. They already have a lot of bleeding and stuff. Everybody told you that sort of the scarring process. Well, this molecule is an anti-PDGF molecule, which is to try to eliminate even the other stuff besides the blood vessels, the other stuff, the scarring areas, etc. And we've shown in early studies that this is able to regress those type of lesions as well. Now, this is all early. We're still working on it, and we're still in clinical trials with it at this stage. Now, my big baby is something called pazopanib eye drops. Eye drops in general. We are in the forefront in the world of developing an eye drop, instead of an injection, mind you, for macular degeneration. We're now enrolling in 2 clinical trials. I'm about to start another clinical trial on another eye drop. So this is novel. This is very, very exciting. Imagine, instead of injecting you every 8 weeks, we just give you an eye drop, send you home. What we're going to do, though, is most likely those people who have a certain genetic mutation, and that's why the genetic test is so important, they will respond better to the eye drops than those who don't have a particular genetic mutation. And we can select you. So let's say you come into the office and you have wet macular degeneration. We do the genetic test, or you might already have it, and we say, look, you can probably use the eye drops because you have that particular genetic mutation. You don't have to get injections. I'm sure that you both will probably be very happy with that, right? So that's what we're working on. And right now it's in a clinical trial, and we're recruiting patients who have never been treated before for macular degeneration with an injection. We're going to start you off with a drop, okay? And that's ongoing, and we're recruiting that actively in the next few months. Now, the other big neat thing that we're going to be working on is something called sustained release. You know, every 8 weeks is great, but wouldn't it be better if it was once a year or twice a year only? And we're working on Macugen, which is a safe drug, right, in a sustained release form. Now, it's really in the drawing stage right now. We're still designing it. It's still preclinical, but it's very exciting because it's a safe drug that we can implant in your eye. And you know, we don't have to worry about you having a stroke or not, because and we know it can maintain the vision over the long term. Bottom line, this is very exciting times. We now have medicines that can actually improve your vision if you have this. And I'll give you the numbers. If we catch you at a time when you still have vision and we start treating you, in 95% of the time, we can keep you seeing at a very good level forever, based on the number of injections you get. Okay? That's pretty exciting. Well, before, where we were going to tell you, we're going to make you blind first, and then, you know, you'll be better off in the long term. Here, we're saying we can probably preserve your 20/20 vision, and and Dr. Dupree and I'm sure we have patients that we've been injecting for 5, 6, 7 years who've done very well. Now, not every patient is like that, but you know, more patients are becoming like that, because when we first started treating, a lot of times our patients were too advanced. Remember I told you, the more scarred they are, the less we can do for you? You know, we still are working on other technologies like stem cells and what we call regenerative medicine to hopefully help people who it's right now don't have hope from these treatments. Well, thank you very much.